Hello, everybody. My name is Kyle King, and welcome to the IOCDF's Research Roundtable, the IOCDF live stream where we pick an interesting topic within the OCD literature and discuss it with the folks who know it best. As I already said, I'm Kyle. I'm a student who studies OCD. I'm also an advocate who's been interested in OCD for a long time, not only because I think it's a very interesting disorder, but also because I have it and I know how distressing it can be to live with it. And as always, I'm joined by my co-host, Jon Abramowitz. Jon, if you want to say a word about yourself.
Sure. Thanks, Kyle. I'm Jon Abramowitz, and it's great to be here, as always, with you. I'm a professor at the University of North Carolina at Chapel Hill, and I do lots of research on OCD and work with folks in clinical work, doing clinical work with folks who have OCD. And I'm fascinated by all things OCD. And today's topic is related to OCD, and it's going to be a lot of fun to talk with three experts about BDD.
Yeah, I've been waiting for this live stream in particular for a while because I feel like BDD is talked about a lot in relation to OCD and also not in relation to OCD. And it's something that I just don't know a lot about. So I have a lot of questions about. We have three panelists, as Jon mentioned, and I will introduce them in a second. I clearly wasn't on the group text when they all decided to wear blazers. So I'm really outdone at the moment, but it's okay. I'll compensate in other ways.
No, that is your finest Hanes white T-shirt.
That you How do you know it was Hanes? I buy the 3-packs from Target. I'm very fancy. But before I introduce my guests, including the one that makes snappy remarks sometimes, I have some announcements to make. First, this live stream is educational and is not intended to replace therapy. For treatment-related questions, please work with your provider or contact a local clinician. You can use the IOCDF's online resource directory at iocdf.org/find-help to locate a trained clinician near you. Also, the International OCD Foundation is not a crisis hotline. If you're in a crisis or if you're feeling suicidal or unsafe, please call the 988 Suicide and Crisis Lifeline by dialing 988. You can also access this online at www.988lifeline.org or go to the local emergency room or call 911. Also, we have a chat function. We love when you guys ask questions in the chat. We'll try to monitor it throughout the stream, and we'll try to ask as many questions as we can. I'm sorry if we don't have time to get to your question, but please put them in there. Just remember that this is live and will live on the internet forever. So just be respectful of what you put in the chat, though we've never had any particular problems. Okay, I feel like that's enough of me talking. Chris, I'm sure you agree.
Yeah, pretty much.
So I'll start by introducing Chris, one of our three panelists. Chris Trondsen, LMFT, is an OCD and BDD clinician at the Gateway Institute in Costa Mesa, California, the vice president of OCD Southern California, a leader of the IOCDF's BDD and LGBTQ+ special interest groups, and a member of the IOCDF board of directors. Since childhood, Chris suffered from undiagnosed severe OCD, BDD, major depressive disorder, and anxiety and panic attacks, only receiving formal diagnosis and specialized treatment in his early 20s. Chris began advocating publicly for mental health and shared his story of recovery on TV shows and various newspapers and websites. Chris began speaking at the annual IOCDF conference, giving the keynote speech with his mom in 2011, and helped to start the conference Young Adult track. As a lead advocate, Chris's passions include expanding BDD awareness and education, addressing LGBTQ+ issues in mental health treatment, and expanding the IOCDF services to the young adult community. Chris, how are you doing today?
I'm good. I'm excited to be here. I'm excited about the topic. So thanks for having me.
Yeah, I'm particularly excited to hear your perspective, both as a clinician and as someone who has experienced BDD and OCD and can talk to the overlap between them.
Thanks, Kyle.
Our second guest, who's, I would say his color combination in the suit and blazer is better than Chris's.
Ouch.
Is Dr. Daniel Rautio. Did I say that right?
Yeah, absolutely.
Right. Cool. He's a clinical psychologist responsible for the care of patients with BDD at the Specialist Obsessive Compulsive and Related Disorders Clinic in Stockholm, Sweden. He is a postdoctoral researcher with Professor David Maciek's team at the Karolinska Institute, and his research mainly focuses on BDD in children and adolescents. Daniel has been in charge of building the clinic's database of young people with BDD, which is one of the largest cohorts of pediatric BDD cases in the world, and has led to the first treatment trial evaluating internet-based CBT for children and adolescents with BDD. David, you seem like the perfect person to have on this particular live stream. Thanks for joining us. How are you doing?
Thank you so much. I'm super happy to be here. Really nice to be part of your show.
Yeah, it's going to be fun. Our final guest, last but not least, is Dr. Katharine Phillips. She's a professor of psychiatry, DeWitt Wallace Senior Scholar, and Residency Research Director at Weill Cornell Medical College, and attending psychiatrist at the New York Presbyterian Hospital. Dr. Phillips is internationally recognized for her clinical and research expertise in body dysmorphic disorder and OCD. She's been conducting research studies and treating patients with BDD for more than 30 years. She has published most of the medication studies of BDD, and she has co-developed and tested CBT for BDD. Her scientific studies on BDD were continuously funded by the National Institute of Mental Health for more than 20 years. She has published more than 365 articles, one per day, and chapters in scientific journals and books. And she has authored or edited 11 books, including multiple books on BDD. She's also given 600 presentations around the world and more than 500 media interviews, so she's much more experienced at talking in front of the camera than I am. And she has received many honors and awards for her research, clinical work, and other academic contributions. Dr. Phillips, it's really an honor to meet you. I feel like it's impossible to look through this topic on Google Scholar without running into your name a couple hundred times. So thanks for being here. How are you doing?
Well, I'm doing great, and thank you so much for inviting me to be here today. I'm really thrilled to be participating in this. Thank you.
Yeah, I feel like this is a great panel of people for me to learn from and for our audience to learn from. So I spent a lot of time thinking about OCD, but I don't spend too much time thinking about BDD. So before we talk about OCD at all, I just kind of want to ask, what is body dysmorphic disorder? And that's for anybody.
Well, people with body dysmorphic disorder think that they're preoccupied with the thought that they look abnormal in some way, ugly. Some use terms like unattractive. Ugly is a very common term, sometimes more extreme terms like monstrous or hideous. And in reality, people with BDD look normal to others, right? So they have distorted body image. And what to them looks so hideous and ugly, to others can't even be seen. Or the flaw, if there is a quote unquote flaw, it's really quite minor. And in addition, people with BDD typically perform repetitive behaviors. Like if you think you look ugly, you're going to want to check how you look in the mirror or excessively groom. And importantly, to help us differentiate BDD from kind of normal, common appearance concerns, the preoccupation with these perceived flaws in appearance must cause clinically significant distress or significant impairment in day-to-day functioning.
Okay, so is it so it's a preoccupation, which is like a fixation, I guess?
Yeah, it's an obsession. Yeah, I look ugly. My skin looks terrible today. My hair looks really bad. You know, it can really focus on any part of the body, but skin and hair and nose concerns are the most common.
And is it typically just one part of the body, or is it multiple?
Well, we found usually over the course of the disorder, people tend to obsess about 5, 6, or 7 different body areas over time. But sometimes it's just one thing, like my chin looks, too prominent, or it could be all parts of the body, right? It can be everything about how you look.
And do any of our other panelists want to add something to the definition?
Yeah, what I'll just say is I think there's a lot of terms thrown out there like body dysmorphia, body image disorder. I think one thing that's very different is having body dysmorphic disorder. It's very chronic. It's not a disorder that like takes time off. So when people might have body dysmorphia, which isn't even a clinical term found in the DSM, they might, dislike how they look in a bathing suit on a vacation that summer, or feeling like their face is looking red because they're out in the snow. It's like a very temporary experience. But individuals with body dysmorphic disorder, like Kathy laid out, I mean, this is a chronic disorder that often we see throughout the lifetime, especially if it's undiagnosed and untreated. I would say also it starts to impact somebody's life in the way of difficulty with dating, difficult leaving the house, not wanting to engage with people face to face. I think with the addition of Zoom and all of this, there's additional difficulties with FaceTime, et cetera, because people are staring at themselves back. So just like we see in OCD all-consuming, body dysmorphic disorder becomes all-consuming to where the individual starts prioritizing their appearance over everything. And just like other disorders in the OCD spectrum disorder, it starts to impact the lifespan to where somebody's life gets smaller and smaller and smaller until pretty much all day, all they're either thinking about or doing in severe cases is something around their body image. And like Kathy said, it's typically neck up is where we see mostly, but that doesn't mean people don't have BDD at other areas of the body as well.
I'm glad you mentioned body dysmorphia. It's become a very popular term, and we hear skin dysmorphia and acne dysmorphia, and it's really, these are popular terms. It's not really clear what they mean, and are they just normal appearance concerns, a bad hair day, or are they just the disorder BDD? And it's important to differentiate because BDD needs professional treatment, right? Mm-hmm. Whereas sort of normal passing appearance concerns, which a lot of people have, don't require treatment. So it is important to, differentiate them. And BDD, causes the preoccupation at least an hour a day and significant emotional distress or significant impairment in function, usually both. And that helps us figure out who has BDD and who doesn't. But I would add, that the severity of BDD does span a bit of a range. And sometimes it completely ruins someone's life. It can lead to suicide. Other people with BDD are less severely impaired, but there's always at least some meaningful impairment in day-to-day functioning. Some of the things Chris mentioned, difficulty going to school, to work, difficulty dating, or significant distress like depression, anxiety, but it's usually both emotional distress and impairment in functioning. That sort of helps us figure out what's BDD and what isn't.
I can just add to that a few numbers. Chris, Kyle, you mentioned the cohort we have in Karolinska. We have collected data, assessed and treated. Now it's close to about 200 young people with BDD. So I'm specializing on the pediatric population. And among those, there are kids, and there's still a third of them had already dropped out of school. Half of them, or more than half, had a history of self-harm and suicidal ideation. 1 in 10 had previous attempt of suicide, and 1 in 10 had already performed cosmetic procedures of some sort, cosmetic surgery, for example, even though they live in Sweden, most of them are under the age of 18. So I totally agree with what Chris and Kathy says. It's normally very severe and functional impairment. But also we have a specialist clinic in Stockholm. We receive all the cases of BDD, even if they are mild or severe. So we have the full spectrum. We have those who have a BDD Y-box score around 20, which means that's quite a mild presentation, but they still have a clear BDD presentation and need treatment, all the way to those who are totally housebound and cannot go to school and have previously tried to commit suicide. So the full spectrum, even among kids.
Mm-hmm.
And
just to add, it usually onsets in early adolescence, right? And
I was going to ask that.
And that's can be problematic because sometimes other people think, oh, this is just a passing phase. This is just adolescent angst, and nothing that we have to be too worried about. But, BDD is problematic as we keep hearing today. And so if a young person is obsessing at least an hour a day total about some aspect of their appearance that they think looks ugly when they don't look ugly to anybody else, and they're quite distressed, or certainly when it's getting in the way of day-to-day functioning and things like dropping out of school is very worrisome, right? Then, you have to think, oh, I think this may be BDD. You want them to see a professional and not just hope it goes away all by itself.
So when I was struggling with my own OCD, I remember recognizing that my thoughts were irrational, but feeling unable to do anything about it, despite that knowledge. So do folks with BDD, do they tend to recognize that other people view them as normal?
No, they tend to have what we call poor or absent insight. They usually, most of them think they really do or probably do look ugly, even though other people don't see them that way. So that that insight is much less in BDD than in OCD. And that's a problem because it means a lot of them want to get cosmetic treatment, which doesn't help. They may be reluctant to see a mental health professional because they think, oh, how can someone help me with how my nose looks or my hair looks, right? Mm-hmm. So that poor insight is very characteristic, or absent insight is typical of people with BDD. And it's probably because they are actually seeing themselves differently than other people see them. That many studies have shown that the brains of people with BDD are seeing things differently than others do, that their brain sees too much detail. It has difficulty recognizing that details are just itty bitty things. And so then details look really prominent. So a spot on the face or a little scar or a little asymmetry of some facial, feature becomes, to them, looks really horrible and out of proportion. And that is probably this aberration in what they're actually seeing, what their brain is seeing. Mm-hmm. That explains why most are mostly certain or completely certain that they really look ugly. And so you can't really talk people with BDD out of their beliefs, right? So if you say, oh, you look beautiful, or your nose looks great, or your skin is really clear, they almost never believe you because they are seeing themselves differently than you and others are seeing them.
And just short add to that, I mean, as a clinical psychologist, it's of course a challenge if you meet a young person that rather would meet a surgeon instead of a psychologist. Mm-hmm. But to say something encouraging, when we have tried to look at predictors, then lack of insight doesn't seem to be a predictor of poor treatment outcome. So if we manage to capture their interest and convince them to at least listen to us and try to stay in treatment and try out the meds or try out CBT, then they have as good chance of someone with good insight to respond to treatment. That is at least my both clinical impression and what we see in our data. I don't know if you have another view on this, Katharine.
Yeah, I think the CBT studies have been kind of mixed. And it's good to hear that you, with your data set, find that poor or absent insight doesn't mean people aren't going to do well with CBT. The CBT studies that have been done, some have found that poor insight predicts poorer outcome with CBT, and others show that it doesn't matter what the level of insight is. Importantly, with medication, and we use the serotonin reuptake inhibitors for BDD, the SSRIs, level of insight doesn't matter. The meds are as likely to work if you realize that you're not so ugly, or if you're absolutely certain that you're ugly. They work just as well across the spectrum of insight.
I just wanted to add something kind of to piggyback off what Katharine was saying. Dr. Fusner has been Jamie Fusner has been a part of a lot of studies. He actually presented at a BDD conference in London this past November. But what I found the most fascinating when looking at the research, similar to what Kathy was saying about how people see themselves differently, is when they were doing brain scans, the left hemisphere of individuals with BDD really lit up. And that's the part of the brain that really kind of zones in on fine details, like Kathy was talking about. And when individuals in some of the studies would see images of faces, either high detail, normal, or with low detail, the left hemisphere of the brain continued to be most active. It's trying, even if there's not a lot of details in the image, it's trying so hard to find these like really minute details in an image, whereas somebody who doesn't have BDD sees things more holistically. So in the images that don't have a lot of detail, the right hemisphere is lit up and they see things holistically. But what I found interesting in the research is it wasn't just with faces. They used images like houses, and the brain still tried to do that. So the research was showing that individuals with BDD really zone in on fine details. And the way that we know that impacts the individual is because if somebody doesn't like a scar on their face or they see acne, I mean, that's really all they're seeing. They sort of tune out the rest of the face and the rest of the body and are zooming in on that. And then with poor behavioral habits, such as being in the mirror hours a day, I can attest to that. And all you're staring at is that body part. So that body part is all you can think about all day. And it just keeps expanding and getting bigger. And so, I find the research is really helpful to clients because they always ask me, well, how come I see something different? And although we're not, definitely this is a cry for more researchers to do more research on BDD. I love what Kathy and everyone has been doing, but I find that clients really resonate with some of the research if they're in the headspace to listen to it, because it finally gives them an answer why maybe they see themselves differently than their friends and their family.
That's really interesting. And I know, and folks that have anorexia also kind of clinically, they tend to focus in on things and literally see things about their body shape, right? That other folks don't see. And I'm curious whether folks have looked at that. Is this there's some overlaps?
Yes, I mean, anorexia nervosa, bulimia nervosa, and BDD all share some clinical features, most notably the distortion in body image, right? And obsessing about your appearance, and some of the behaviors, the repetitive compulsive behaviors overlap, like excessive mirror checking. Interestingly, Dr. Jamie Fusner, who Chris just mentioned, who's been the lead researcher in the area of visual perception in BDD, did a study directly comparing people with anorexia nervosa and people with BDD, and found, similarities, not finding the hyperactivity. People are in a functional MRI scanner while they're looking at pictures of faces and houses, and finding some similarities in brain activation while looking at these images between the BDD participants and the anorexia participants. And in addition to the excessive detail that people with BDD tend to see, there's also a part in the back of the brain, the occipital lobe, that's underactive in people with BDD. And that part of the brain is specialized for seeing the big picture. It's a global, holistic visual processing that enables you to realize details are just tiny things. So you see this imbalance where the brain sees too much detail and can't contextualize it and realize that it's just tiny. And so Dr. Fusner, in his study of anorexia nervosa and body dysmorphic disorder, found similarities in visual processing aberrations, but some differences. And the people with BDD had more severe aberrations in visual processing than those with anorexia, which kind of fits with studies that have actually found poorer body image related insight in BDD than in people with anorexia nervosa. And importantly, just to throw in that the treatments are somewhat different for the eating disorders versus BDD. So that's important to keep in mind.
I think we're better at treating BDD than we are with like anorexia, for example. I don't think there's
BDD, I think, is just as severe, and it depends, not so much medically severe as anorexia can be, but in other ways in terms of social avoidance and poor insight. Actually BDD tends to be more severe than anorexia, but our treatments for BDD are much more effective. And bulimia nervosa is pretty treatable for most patients, but which also involves distorted body image. But despite its typical severity, we have great treatments for BDD. And the problem is people not getting them, right? But if people get them, if the medicine is chosen correctly and dosed correctly, if they get the right cognitive behavioral therapy, most people with body dysmorphic disorder do get better. So that's the good news.
The visual processing stuff and the treatment stuff has all been super interesting. I guess one question, and this is like maybe more high level, like you find that the left hemisphere is slightly more active in people, or more active in people with BDD than I guess controls. Is it possible to glean this is slightly more red on this fMRI, therefore people with BDD must be paying more attention to detail. That's the etiology. It seems like a tenuous connection, but I don't know. I'm not a brain surgeon.
A lot of different types of studies have looked at visual processing in BDD. Some of them are with people in a functional MRI scanner, which shows the activity of the brain while they're looking at photos. Some of the studies are done on computers. An early study we did was sort of a type of neuropsychological testing where people had to redraw a complex figure from memory. And all of these studies kind of converge, most of them, in finding that the brain is too attentive to detail and has difficulty seeing the big picture. So I think this is a very consistent finding.
Is it not the same in OCD where you have that kind of fixation on detail?
Yeah, I'm not sure I think there's some neuropsychological studies showing some attention to detail, visual attention to detail in OCD. I don't think the kinds of studies that Dr. Fusner has done with functional MRI have been done in OCD, as far as I know. One thing that is similar between the two disorders on MRI, showing the activity of the brain, is hyperactivity in a part of the brain called orbital frontal cortex. And that's a very consistent finding in OCD, that there's hyperactivity in that part of the brain. And it's made worse when people are exposed to whatever their OCD triggers are while they're in the fMRI scanner, like, a germy towel or something, that hyperactivity gets even worse. We found the same thing in BDD. The same hyperactivity in the same circuit, and it probably reflects the obsessive thoughts. And that's
those studies are fascinating, and they're correlational, right? So we can't say cause and effect. We can't say, to your point, Kyle, we can't say, oh, this is the part that's lighting up. It's broken, and that's what causes the BDD. What we can say is that when a person has the experience of BDD, and it does happen in OCD, people are very attentive to feared stimuli. That's part of the fight or flight response. What's cool is that we can see, what's being activated in the brain, when that's correlated with that experience. But as far as causality, does one cause the other? We don't have the data to be able to, say that for sure.
Just to briefly add, that doesn't mean that people with OCD or BDD have brain damage, right?
Exactly.
It's just a temporary, hyperactivity in parts of the brain. The brain's working a little too hard. Yeah. And in OCD, we actually have studies showing, that medication or behavior therapy will normalize that hyperactivity that we can see on neuro, on imaging, on fMRI. We don't have those studies in BDD yet. Presumably the same thing is happening. That
you would think, right?
Normalizes it.
Yeah, I was just going to, maybe I'm stating the obvious here, but just to, in response to your question, Kyle, that the brain is, of course, a physical entity. That is something that we can study, and the DSM diagnostic categories are man-made constructs, of course, of symptom clusters. We're not going to find these defined categories in the brain, but we're going to, of course, it's a similar disorder, OCD and BDD. It's going to be a significant overlap, and still much more research is needed. We have to look more into the brain and different processes.
Mm-hmm. I want to ask more about the overlap, and I'll get there in a moment. But we had a lot of great audience questions during that whole interval, so I want to say some of them now. First, at 1209, I like this question. Dottie Doan, I hope I didn't butcher your name, asked, what about skin picking? And I thought about that too. Like, excoriation seems to me to be very similar to BDD. So is discussed.
About 40% of people with BDD over the course of the illness compulsively pick their skin, because skin is the most common concern in BDD. And they compulsively pick it, trying to make it look better. But like all the repetitive rituals of BDD, the behavior is hard to control. It's hard to stop. And sometimes people use sharp objects like staple removers, pins, needles, knives sometimes. And they can actually damage their skin. So the people who pick their skin as a symptom of BDD may have actual skin damage that others can see. So they are an exception to the rule that in the eyes of others, people with BDD look normal. It is different from excoriation skin picking disorder, which is another disorder in that chapter of DSM, our diagnostic manual, in the obsessive compulsive and related disorders. Excoriation disorder also involves skin picking, but it isn't triggered by a thought. In BDD, the skin picking is triggered by a thought that my skin looks bad, or I have to fix this pimple, I have to fix this thing on my skin. And it's a great question because it's very important to differentiate skin picking as a symptom of BDD from skin picking excoriation disorder because the treatments are somewhat different. The medication treatment is different, and we use a behavioral strategy called habit reversal training for excoriation skin picking disorder and for skin picking as a symptom of BDD. But when you have BDD, you usually have all kinds of other symptoms that you have to use other cognitive behavioral therapy, strategies for.
What I just wanted to add as a person who did skin pick because of BDD, for me, just like Kathy laid out, it was all about trying to get rid of bumps on my skin, like acne and stuff. And so I would spend a lot of time either getting up close in the mirror or kind of feeling my skin to see if I felt bumps. I would use tweezers, and I would take like an acne pad and kind of like dig into my skin with the tweezers and try to get the medicine under my skin. I do say, like, when I work with clients who have a BFRB, excoriation disorder, skin picking, I don't relate the same way like I do relate to a client with BDD that skin picks. It's much more about trying to fix a flaw, trying to get something, to look different. It's not really out of boredom, or it's not really out of stress or anxiety. It's always was being in the mirror. And just like, as laid out, what really helped me first and foremost is getting rid of the tool. So not having tweezers in the home, but also kind of looking at like what kind of led up to the action. So it was often like being at home alone, getting into the bathroom, leaning into the counter, getting up close in the mirror, having the bright light. So it was really kind of reversing some of those habits that led to that. And also finding that just recognizing, with my clinician that it was actually causing more damage, and became a horrible cycle because it would often aggravate the skin, create new acne, and then I was picking at it again. So it was a difficult process, but it was part of the treatment and it worked. I don't skin pick anymore, but I would definitely say it's different than somebody who has a BFRB because it was always appearance-based.
Okay. So I guess in the differentiation, it's like crucial to, I guess, ask like, why are you doing this, and get to the bottom of it.
That is the question. And and if it's not clear that if the answer is not clear, you ask, are you picking to try because you're unhappy with some how your face looks and you're trying to make it look better? Yeah. Ask why you're picking. Perfect question.
This is vaguely related, but it was a question that was kind of triggered by our conversation there. Do you attempt to build insight in folks with BDD, or do you just kind of go straight into CBT, more behavioral treatments?
I would say the treatment is not about you're not trying to get in the weeds with their appearance, right? But I think any goal of treatment is to help somebody get some insight. So when we see clients, it was mentioned earlier, often we're not the first line of their recovery. They've often seen a cosmetic surgeon, they've seen, a dermatologist, they've seen a cosmetic dentist prior to us. So they've come to us because either they've read about BDD, a family member has encouraged them to come. So often the client is coming in not even really sure if this is the right space for them to be in. I would say working with both OCD and BDD, often my clients with OCD know something's wrong. Somebody with BDD is like, I'm here because my mom is asking me to be here. Or rarely, but sometimes it's like, a plastic surgeon is like, hey, you need to go see someone for your mental wellness because something else is going on. But part of the goal of treatment, and I think part of the beauty of the treatment, is to gain insight. Where I am today about my body image and my BDD is way different than I was before. I can see pictures. I think one of the most eye-opening parts of the treatment recovery is looking at pictures that I used to hate from my worst times, and looking at the picture now and being fine with it. Like, actually, it's the same photo, but I would argue with a different brain now after treatment. So it's definitely really working with the client on insight. But with that said, I think one of the mistakes newer clinicians treating BDD will do is they'll try to reassure the client, no, your teeth don't look big. Let me show you a picture of teeth. Let's measure your teeth, like trying to almost convince them that their appearance isn't bad. And that's just not really the point of treatment. And so I think that is a big caution that we've talked about in the trainings we've done for the BDD SIG, is really recognizing that the treatment is not about going back and forth and trying to convince your client they're beautiful and have no reason to have any issues. That's not effective treatment.
Yeah, I completely agree. It really doesn't work. And it just sort of triggers more reassurance seeking, right? And the patient typically doesn't believe what you're saying because they're seeing themselves differently, right? So, but yeah, as Chris said, during the course, cognitive behavioral therapy and medication both usually improve insight. And at the beginning of treatment, I just briefly mentioned some of Dr. Fusner's wonderful research findings about seeing, the visual perceptual differences between BDD and those without. Just not to convince people of anything, but just to say, like anorexia nervosa, if you're familiar with that, people with BDD see themselves differently than others do. But having prolonged discussions about appearance and how people actually look is not all that helpful, but the good treatments we have do usually improve insight.
And also, as I talked about before, it's about buying time when you work with kids. Maybe their goal is to, when I turn 18, I will get a nose job. Mm-hmm. But then you may have 1 year or 2 years before that, and you can say, you're not going to be able to do that. So at least give this a try and listen out and see what happens. And then after a couple of sessions or a couple of months or longer time, then we incorporate techniques from motivational interviewing, basically try to not convince them, but listen to them and validating their anxiety. And my impression is that they can do as good in treatment as the ones with low motivation initially.
And I'd just love to add to that. I mean, that's one of the things that we really try to do as clinicians. Like, often my clients will tell me first session, like, I'm okay with being here and I have a surgery planned on this date. And so obviously, I'm not their parent. I'm not going to, prevent them from going. But one thing I do ask, obviously, if they're under 18, we have that benefit. But one thing I do try to ask is, would you be willing to put that off for a little bit, really dig into this treatment, and then we can reassess when we're further along. And I'm so happy to say, and this seems to be the consensus through most clinicians, is often our clients then choose not to do the surgery or not to do the procedure after they've gotten some treatment and really learn why they are so urgent to get the procedure. So that's one of the things that we try to do, is have someone at least delay so that they'll be willing to do the treatment first.
And that's a great strategy, because everything we know about cosmetic treatment indicates it almost never helps BDD, and it can make it worse. And it kind of makes sense, because the problem with BDD is not how you actually look. It's your distorted body image. And also, people with BDD, as you've heard today, are just so hyper attentive to detail, right? So the surgery or the dermatologic treatment often doesn't go the way they want it. And they now may think they have a new flaw, or now their nose is even more crooked. And so I've seen patients who've just been so devastated by what they perceived as a bad outcome of surgery, even though it looks fine to everyone else, but their brain just sees too much details. And it makes sense. Cosmetic treatment wouldn't help. So, and it's still a super important issue, because correct me if I'm wrong, Katharine, but the latest prevalence studies show that it's up to 15 to 20% of the clients to dermatology and cosmetic surgery settings may have BDD. So it could be 1 in 5 or 1 in 6 of their clients. So a plastic surgeon can see a BDD case every day. So that's a huge responsibility to try to screen for and assess for this type of problems, so you can push them in the right direction and recommend treatment that actually works.
And what I want to add to, Kathy lays it out really well in the broken mirror, and we see it clinically as well. So I just want to really highlight to anybody watching that's thinking about getting filler, thinking about getting veneers, thinking about getting plastic surgery. Not only does it typically not work, obviously, because it's not about appearance, but it often creates new problems. Either the surgery didn't go as well as I liked, or, now it makes this part of my face look worse and stuff. And so I think there's a lot of times people are so desperate that this is the answer. And so one of the things that I would like to see moving forward, I don't know if it's something that we can do in California, in the United States, because we're pretty supportive of capitalism. But I know we have somebody in our special interest group who's in Canada, Natasha, and what she's trying to push through legislation there, and they seem to be a little bit more receptive, is requiring a BDD screening at plastic surgeons and other cosmetic offices, so that they could screen for BDD. That would be one thing that could potentially help our field, because often plastic surgeons will claim that people with BDD are their best clients, and so they're not really open to working with our community. But that's a dream. That's a hope.
I just want to give a quick shout out, Chris. You mentioned The Broken Mirror, and that's one of Kathy's books on BDD. I remember being a graduate student in the 90s and reading that as the first kind of foray into learning about this. And it's certainly something that if folks are interested, that's a terrific resource.
Yes, my mom and I used to read it when I would have breaks between my BDD sessions, and Dr. Fusner was my psychiatrist. So between my therapist and my psychiatry appointment, we used to read it. And I think in addition to just being good research-wise, I think for me, not meeting somebody with BDD, the Broken Mirror uses a lot of really good case examples. And it was the first time like reading about people like me. And I think it gave me hope. And so I would absolutely recommend it as kind of like the first stop. Anybody watching this, whether you're a clinician, whether you're a researcher, a parent, or a person with the Broken Mirror, is sort of, to me, like all encompassing. And I know for me, it was sort of like my support system through treatment. So I've always told Kathy, thank you. I mean, she pretty much saved my life. But what I do want to say is that there's hope. And I hope people keep hearing what we're saying up here, is that people do get better. So I hope somebody watching this is encouraged to really seek out treatment.
I want to
thank you, Chris. I just want to mention your kind words mean so much to me. So thank you so much for that. I do want to mention, though, that we have learned more about treatment since I wrote that book. And so I do have more updated books, which are more up to date in terms of treatment, because there's a lot we didn't know about treatment back then. And a lot of the treatment studies hadn't been done. But also, I have recently posted some blogs on the IOCDF website about medication treatment of BDD. So those are probably more up to date, if you're interested specifically in how to treat BDD with medication.
On a slightly different topic, so at 12:35, Tom W. asked, is BDD sometimes associated with psychosis or delusions too? Because we've been talking about these kinds of, perceptual disturbances. Should these presentations be approached any differently? What would our panelists say about that?
Yeah, about 1/3 of people with BDD currently have what we would call delusional beliefs. They're completely certain that they look abnormal or ugly when that isn't true. And we don't consider that a psychotic disorder. We consider it a form of BDD, and we would really treat it the same as we would treat BDD with better insight, so with cognitive behavioral therapy, and even with an SSRI alone. You would think, oh, you need an antipsychotic for medication for a delusional belief, but we find SSRIs alone work just as well. Sometimes we do add in antipsychotic, also known as neuroleptic, like aripiprazole, as an add-on medicine if an SSRI alone doesn't work well enough, just as we do for OCD. But we really treat the absent insight form of BDD the same as we would treat BDD with better insight.
I just want to add to that as well, is that one of the things that I usually hear if a client comes to me and they have been diagnosed with some kind of psychosis or delusional, often it comes because the person with BDD is like, I see people laughing at me, I see people staring, I see people making faces towards my appearance. Once again, to shout out Dr. Jamie Fusner. And there's also a really good video up from a lab out in Australia that did research on this as well, but they found that people with BDD misread faces. And so, in the studies, they've seen faces and they struggle a little bit to identify what emotion that they're experiencing or matching the emotion with the face. And so once again, I think in BDD treatment, the education part is so important in the beginning. Like Kathy said, it's not to convince them of anything. It's to provide them with the research that we have and sort of like walking them through it. But a lot of times when clients see like, oh, individuals with BDD misread faces, I may not believe that right out the gate, but it's interesting to know that that's potentially something that's experiencing. And typically through the process of treatment, they'll often start to see faces more regular, et cetera. So there's not as much as that paranoia, but that's when I see people get misdiagnosed with psychosis, is everybody talking about me staring and laughing. Yet, the research shows why.
Now
I'm glad you mentioned that, because that is one other symptom of BDD that can appear psychotic, right? The delusions of reference. But again, you don't have to use an antipsychotic to effectively treat that.
That, Chris, your point brings up another question for me. So in social anxiety, we see some of the same, misreading faces. Is that person upset with me? Even though they have, they're not expressing that. And so I'm curious about overlaps that you all see? One could look at body dysmorphic disorder and think social anxiety, right? I'm afraid I'm going to go out in public. People are going to judge me negatively based on a certain aspect of my appearance that I don't think is right. I don't know if you all see that.
Yeah. There's a lot of social anxiety, a lot of social avoidance, because they think they look, ugly, and they're going to be negatively judged, and they think people are laughing or staring at them. So I think there is a lot of overlap, but some differences. And the treatments both overlap and have differences. In OCD, for BDD, the ritual prevention is so important, right? And there's a little bit less of a focus in social anxiety disorder. Medication treatment, a little different. We might use an SNRI, serotonin norepinephrine reuptake inhibitor, perhaps, for social anxiety disorder, although I prefer the SSRIs, whereas we would not for BDD or OCD for that matter, almost never. So, some interesting similarities, but also some differences.
I guess we've talked a lot about like treatment for BDD being helpful, but I'm personally a little unclear. Like, what is treatment for BDD? Like, is it CBT with exposure? Like how does it work, and how is it different than treatment for OCD?
I'm super happy that Katharine just mentioned the rituals, because me as a BDD researcher, I've tried to read everything Katharine has written, and I also starting to form my own clinical experience working with kids with BDD, and I have landed in that response prevention and ritual prevention is key here, and it's the same treatment basically that we have had for OCD for decades, ERP, exposure and response prevention. But if you think of a young person or a person with BDD, if you manage to get them to stop their excessive use of makeup, excessive checking, and their rituals, then everything you do that day is a really good exposure task if you've managed to leave the house. So if you start in the response prevention, and as in OCD, as you know, the devil is in the details. You have to be really thorough together with the client and find all the rituals or safety behaviors or avoidance behavior, and together with them, step by step, encourage them to drop them, and then go out and do social things, which really are the exposure tasks.
I would say I agree very much. I think I tend to push the exposures not quite as hard with BDD as we do for OCD, because they're very difficult for people with BDD. I think I always add cognitive restructuring, helping people to develop more accurate beliefs about how they look. And, we may or may not in OCD. So I think that's a difference. But it's a little harder to do that with the younger patients who you tend to see. But, a thought like, oh, no, I can't go to that party tonight. My skin looks horrible and everyone's going to think I look like a freak. It's kind of that's a BDD thought, right? And but it has a lot of cognitive errors in it, right? Mind reading, fortune telling, catastrophizing, all or nothing thinking, labeling, calling yourself a freak. And so we help people learn about those cognitive errors and to develop more accurate and helpful thoughts. We also work on, in addition to the ritual prevention that you mentioned, Daniel, we also do some mirror retraining, but it's not staring in the mirror. Staring in the mirror is a ritual we want to prevent with ritual prevention. But it's just a quick, 5 minutes a day exercise where we try and help people enhance their holistic visual processing, seeing the big picture, which we talked about tends to be underutilized in people with BDD. They have trouble seeing the whole. They just zero in on the details. So we have them describe themselves fairly quickly from head to toe, not zeroing in on the things they hate, which is what they usually do, and describe themselves in a non-judgmental way. As Chris said, we also have to work on the desire for cosmetic treatment. That's different from OCD. If they're skin picking or pulling out their hair as a symptom of BDD because they think their skin looks ugly, or they have an ugly hairs they have to get rid of, or they think their eyebrows are asymmetrical, we use habit reversal training for that. So there are some we more often need behavioral activation in BDD, I think, because people tend to be more depressed when they have BDD compared to OCD. So I think it's a more complex treatment, and it needs to be a longer treatment than we would typically use for OCD. Most people need at least weekly treatment for 6 months, but some people need less than that, and some people need a lot more than that.
I just want to add to, they both said everything perfectly. I just want to add, I think treating both and even having both BDD and OCD, I would say there's much more of a cognitive component of BDD treatment. I see a lot of cognitive rigidity. Like, I look like this, you can't tell me anything. So you're really kind of working on helping them see just the errors in thinking, the rigidity in thinking. The only other thing I want to plug is one thing that I often see, maybe it's just because where I work in California, it's such a diverse population, but it's really helping the client look at what are some of the influences of how they feel about their appearance. So for instance, like I work in a heavy population with Asian and South Asian individuals. And so there's some fixations about skin lightness and tanning too much and being too dark. I work with clients in the LGBTQ community, and we know that gay men are some of the more likely than heterosexual men to do plastic surgery and things like that. So sometimes somebody's cultural background, et cetera, can also have influence. Sometimes I have clients whose parents have BDD. And so there was a lot of rigidity about appearance and emphasis on appearance growing up. So I think with OCD, we don't spend as much time trying to figure out any of that stuff. But I find with clients with BDD, they're getting messaging from their family. Like, you look better if you're light skinned. And obviously they're taking it to an extreme, such as not leaving the house, blackout curtains all day, etc., and then miss seeing how they look skin tone wise. But sometimes there is kind of like those other influences that we might want to look at if it's really influencing them.
Those are great points, Chris. And it also, for me, brings up, the last 15 years or so, we've seen a growth in the use of social media platforms.
Yes.
Right. Which people are portraying themselves looking good. They're touching up their photos and all of that. And I'm just curious what you all think about the role that plays in the prevalence of this. Have we seen any changes, any studies on the relationship between, social media consumption and BDD?
It's such a great question. We have 2 small studies, but they're cross-sectional. They don't look at, symptoms and use of social media over time.
Right.
So we don't know, and they're small. We don't know if use of certain forms of social media increase the risk for BDD and therefore might be increasing the prevalence of BDD. As a clinician, I would say yes, using certain forms of social media, focus on appearance and unrealistic beauty standards and have you morphing your appearance almost certainly are a risk factor for developing BDD. But social media is definitely not the only cause, right? We know there are genetic risk factors. Life events probably play a role. The cause of BDD is very complicated. We don't fully understand it. But I think use of certain forms of social media probably increases risk of getting it. I know it can make BDD worse for people who have BDD. Sometimes we have them delete the problematic apps or certainly cut down on their use of some apps that we think are not all that helpful, making them feel worse.
Absolutely. So in that case, it could be a part of treatment. I agree with what Katharine says, because I think your own prevalence estimates from like in the 90s is the same as we estimate today. And that was before the social media era. And we also know that the first guy, I think it was, that was diagnosed with dysmorphophobia was in 1891. It's a long time before this. So it has, and I think we're going to try to do studies to find a timeline in Stockholm Karolinska. They've done similar studies on ADHD, where you can see that the ADHD symptoms do not increase in the community, but the number of diagnosed cases increase. And that can be because of many things. Increased awareness of all the incredible work you do at the foundation and Kathy's work. Of course, if you know about the disorder, more people get the correct diagnosis and you talk about it. So it looks like it's increasing, but it's an empirical question, and we can get back to you when we have some.
If it's okay, I'd like to just briefly, you asked about treatment differences between BDD and OCD, I think, and we talked about the CBT, similarities and differences. But just to mention medication again, because it's important and it usually helps people and it can be life-saving. The medication approaches for BDD and OCD are very similar. So we always use the serotonin reuptake inhibitors, the SSRIs, as a first-line treatment. We often need higher doses in both disorders, like up to 120 for fluoxetine, Prozac, up to 400 for sertraline, Zoloft, up to 60 for escitalopram, Lexapro. We sometimes do add in something like aripiprazole if a good SSRI trial isn't enough. And with the right medicine choice, an SSRI, and with a long enough trial, at least 3 months or even longer, and getting up to a high dose if you need it, most people get better. So there are more similarities in the medication approach to BDD and OCD than there are for the cognitive behavioral therapy.
One thing I wanted to mention real quick, because we haven't brought it up, kind of going back to the social media, but one of the aspects of BDD also is muscle dysmorphia. That is actually in the DSM. We haven't talked about that, but that's where an individual feels like they're not muscular enough. Often we see this in gym communities. I used to run gyms, and I would see that constantly, just people not thinking they looked muscular enough, often turning sometimes to illegal substances like steroids, et cetera. But one thing I find with I work with a lot of young teens and young adults, and a lot of my clients, typically male, but not always, are going on social media, comparing themselves. We haven't talked about comparison. That's a huge compulsion in BDD, but comparing themselves to, kind of like gym influencers that are in the gym, 25, 26 at a certain muscular state, and then really trying to strive for that. And often, not even recognizing that person might even not be natural. They might be taking things and trying to compare. But that's one place that I see social media. Obviously, it doesn't cause it, but it's just another way to kind of ritualize and to compare. And so, as mentioned, that's something that has to be worked on in treatment as well. As like, who are you following? How often are you going on the app? What are you using the app for?
Yeah, it's interesting because like within my community of like college kids, I feel like it's just generally accepted that social media contributes to these sorts of negative self-images and could lead to something like BDD. So I guess it's interesting to hear from you guys that like it is unclear.
Well, it's so, as Kathy would say, there's so many factors and we don't understand squat. Yeah. Right. I mean, for everyone, it's probably a little bit different. We have hypotheses about different things, but we really haven't looked at the combinations and how these things kind of work together. I mean, we have no idea of exactly but the fact that, I mean, how can these things not, play a role?
And studies do show that use of certain forms, image-centric social media, focusing on appearance, for example, does tend to make body image worse.
Yeah.
But BDD, the disorder BDD, there are only these 2 small studies, right? So do the findings about body image more generally apply to BDD? Why they probably do, but we don't know that for a fact. Probably.
It seems like a safe assumption.
I think so.
Given that these things occur on a continuum, it's not like COVID where you either have it or you don't.
Yeah.
Right. It's.
We do have our cut point, right? Because if you're preoccupied at least an hour a day, and that causes clinically significant distress or impairment in functioning, that is a cut point where you need treatment. Right, if you're over that threshold. But it is a little bit like blood pressure, right, where we have these cut points, but there's also a continuum.
Yeah, if you have 58 minutes a day, no one's going to say, "Oh, we're not going to."
Exactly.
I was just going to say, having BDD. I mean, when you look at our culture, right? Like we uplift good-looking people. They often are in movies. They often make good money. People revere them. And then on social media now, there's so many apps to alter the appearance. And so, as somebody with BDD, and I'm sure other people with BDD can relate. It's like you're constantly looking at good-looking people being lifted up, and they're we idealize that. And so it just adds to the I'm another, I don't look like that. It must mean that I'm not going to have those things. So even though we don't have the studies yet, I do believe that it's important for clinicians or people with BDD to look at how they're using not just social media, but it can be how are they comparing to their peers in class when they're going to a mall? Are they staring at other people's noses and comparing that nose looks better than mine, therefore I look bad? So it's important to make sure that comparison is addressed as well, and what forms of media are people using to compare.
One thing just I'd like to briefly mention, if I have like 15 seconds, is, I know we're getting close to the end. You have to be aware of the high rates of suicidality in BDD.
Yeah.
They're very high in terms of suicide attempts, suicidal thinking, and actual suicide, higher than in OCD, perhaps higher than in any other psychiatric disorder. So you always have to be aware of that. If you're a clinician, if you're a family member, ask about it. You won't make someone think about it by asking if they have thoughts that life isn't worth living. But very important to keep in mind when you're treating, when you are living with BDD, when you know someone with BDD, or as a clinician, and our treatments almost always improve suicidality. So something important to be aware of. Treatments usually make everything, just about everything better: functioning, symptoms, suicidality, etc.
We're at one. Unfortunately, though, because I have a question sheet and we only got through about half of it. So I think we'll probably have to have a part 2 discussing BDD and OCD and talking more rigorously about the overlap between the two. But I want to thank you all for joining. This was incredibly interesting. And thanks to everyone who watched. I have a couple announcements. First, the ICDF is a donor-supported nonprofit. So if you want to make a donation to keep programming like this going, that's much appreciated. Also, we'd love to hear from you. You can take a live stream survey to tell us what parts of the live stream you like, what parts of the live stream you don't. And we look forward to hearing your feedback. You can find that form at iocdf.org/live-stream survey. And just remember, this live stream is one of many, and there's an entire schedule of future live streams that can be found at iocdf.org/live streams. I believe there's other live streams that talk about BDD, but I want to do another one. Just so that I can talk to all you guys again too. That would be cool.
This is great. This is a great panel.
Yeah, this was really, really interesting. And I hope to see y'all again. And thanks everyone for joining.
Thank you for having us here.
Thanks for coming on.
Thank you so much.